So this is a reflex hammer. This is obviously a very versatile one. You can do all kinds of stuff. You can do this. You can change it around. It doesn't have a sharp tip on it. This is the only kind of reflex hammer we have. We have the other one. Okay. Aha, a tuning fork. All right. So I'm just going to use this reflex hammer, flip it around where it's weighted a little bit better. Nah, it's the same one as that one. I appreciate it though. That's really cool over there. But if anybody has a triangular wedge shape one, I'll use that. It doesn't matter. It's going to make a reflex, okay? So with a reflex hammer, there's different things that we can do. Of course, this is going to check. Yes, that's perfect. Can you bring that one up to me? There's different things that we can do, okay? This one's been around a little while. What have you done with this? This has obviously got the sharper edge to look for some of the upper motor stuff, and then we've got the triangular shaped component. And you know, when you do these, you can hold it right here so it has the exact same amount of force if you are into that kind of thing, okay? So with reflexes, we're looking for the loop between the sensory input and the motor output. Now, reflexes mean a lot because you really want to be able to tell, is this an upper or motor neuron lesion? I mean, that's sort of basic neurology. So you want to be able to say, hey, does this person have signs of upper motor damage? So that could be like spinal cord, brainstem, all the way up to the cortex. So there's really two ball fields that you want to be able to get into immediately, and that is, am I playing in the upper motor game or the lower motor game? Or are neither there, and I've just got some sort of other functional lesion that doesn't show up as either one, okay? So, simple stuff, this reflex hammer can really go a long ways. One of the very first things we can do is just check a jaw reflex. So, you can just put your own finger there and tap, and you don't really want to see things snapping shut really tightly, all right? You can also say, hold your eyes open, don't blink. You can tap in between, and you shouldn't see somebody blinking over and over and over and over. People with different types of cortical failure, dementia, you'll start to see them, they don't have the ability to inhibit a blink response. Okay? Now, you can go in and tap over the upper trap area, and you don't really necessarily want to see large reflexogenic movements that spread into different parts of the limbs. When we have reflexes that have a pathological spread, that is not a good sign. All right? Now for the bicep response. Come on, let's go. Use those fingers. The complaint letters are going to start rolling now. Okay, so one of the best ways to do the bicep response is just get the arm at 90 degrees. And I like to feel for my reflexes. So you watch them, but I like to feel also. Everybody see? I get a tissue pull right here on the aponeurosis of the bicep. Pull it down a little bit. Stabilize the other finger on the olecranon or the ulna, proximal ulna back there in the back, and then tap. Now, if you'll watch this inner portion of the bicep, you'll see it move. Now, I have his hand against my body. I like that. Just joking. For those of you that are wondering, you're wrong, okay? And when I tap, I can feel his hand lift and move. Lift and move. Now, I've got my thumb down here on the tendon. I can feel the tendon move. And then I can watch the bicep contract. Probably the hardest reflex in the upper extremities. Now, a lot of people, they just go, and they just barely tap. I'm like, come on, man, just make sure you learn how to give the exact same amount of speed on every reflex. Okay? If you can't get the reflex to occur, you can have them valsalva, you can have them clench their teeth, you can have them contract their legs. Clench your teeth, contract your legs. And it may accentuate the response. Okay? So that's a bicep response. Which nerve? Root. Is it just one? You know, books love to say, oh, it's just maybe 5 or it's just maybe 6, but it's really both because, look, the bicep is innervated by 2 nerve roots. Okay? So then we're going to come back here, and I like to take the arm and hold it like this. So I went from this position to this position. And I like to watch right here. This tricep response. So you can see a little wiggle of the tendon, and then the arm will swing, and then I can feel the muscle. So I just, if you put a tissue pull on the muscle that you're hitting, that's not the best idea. But I just barely have my thumb on there, and now I'm checking that response. Everybody see it kind of move? It moves almost proportionately to the amount of movement from this, which is what you want. You want your extensors to be about the same as your flexors. Now, the next one is brachioradialis. Now I'm going to, for the purpose of the camera, I'm going to come across, and on this, we want the hand to be hanging down, and now I'm simply going to watch the hand move. Does everybody see that? And it moves about as much as the arm did in the tricep and the arm did in the bicep. Do you see how they're all very symmetric? Obviously 0 means there's nothing, and then you can go all the way up to 4s and 5s where you may have clonus or sustained contraction, and then you can of course gauge these somewhere in the middle. Okay? Oops. So now we can even do some more interesting stuff. We can come down to the hand. Really, you can do a reflex on any muscle that you can tap. So when somebody is hypoxic or they have irritable membranes, you can do something called percussive myotonia. Do you see the sustained contraction? So when somebody has a little bit of hypoxia or a little bit of fatigue, quiver, quiver, quiver. Now some people will come across and will just stick. Now tapping this muscle is not all that. There's also median nerve integrity and there's lower nerve root integrity. So if you hit this and have no response, that may be part, I would do that with my muscle exam. Now watch this. You can check ulnar nerve. Does everybody see that? So you can go there, you can go there, you can flip over, let that finger go. And if you'll just watch this finger, there it is, you see it?
Yes.
Do it again. There it goes. That's your first dorsal. Now, you can really get sort of jiggy with it and hit some of your intrinsics in here and watch each finger wiggle side to side for your lower cervical, these are really more upper thoracic T1 types of lesions. Now, when you start to get those lower cervical, upper thoracic lesions, especially upper thoracic like T1, if you look at the hand like this, you'll see guttering or rutting. Gutter, like at a bowling alley. If you hold your hand up, there should be enough meat in there to where you don't see the prominence of the bones through here. If you start seeing that, the more you age, you may lose that a little bit. But some of you are like, oh my God, it's there. Well, maybe you're not a spring chicken. I don't know. So we have here, here. We can come around to here. Now the only reason why I'm teaching all these in the hand is because we have this. If this one's gone and this one's not, and you have weakness here but not here, that may be your pattern 1. If this is gone and this is gone, but sensory is still intact in 5th and half the 4th, that may be pattern 2. Pattern 3, now sensory is gone here and in half of the 4th, and you have your 2 that are gone. And then really, anytime you do a Tinel, put tension over the area and just barely tap. Now guys, anything that changes sodium and potassium concentration gradients can perpetuate the probability of a positive Tinel. It's not the greatest test. Like if I go like this, do you feel any tingling? Yeah, okay. He's got carpal tunnel, let's do surgery. Probably not. Is this positive?
Less.
Yeah, less. So just, if you get a huge response with a small tap, that is different than a response with an enormous smacking them, okay? So I just worked all the way down the arm. You can do different muscle groups, but it's really just, you can stay here, stay there, and stay there, and you've got really good stuff. You can work all the way down into the hand. Now these are not conventional reflexes. And if they're there and they stay, they fire a little bit excessively, these are not necessarily the same as if you do like ankle and have sustained clonus. These do not necessarily mean upper motor. Like when we tap this, it sticks around a little bit and you can see it's still quivering. That is not a sign of an upper motor pathology. Alright? So there's your hand. And then you can do things to where you challenge the fingers and see if the thumb or the hands curl in. So you can do things where you like slap the hands with like these Hoffmans. You can slap and see if the hand curls up. But what you really want to watch is look at the tip of this thumb and see if it ever does this right here. Just subtly goes like that. So I'll get the fingers and snap them like this, and I'll watch and see if the thumb curls in with it. And these can be upper motor findings in the upper extremities. And the real subtle ones you can see in the tip of the thumb. Alright? Now, go and stand up for me. We can use this other end of our reflex. Do you mind showing a lower abdomen?
Oh, sure.
So just unbutton your, this is odd. Just unbutton your lower shirt. Yeah, music please. 70s music. It's sort of you have to have some of that stuff going on. Okay, so open up. Now, superficial abdominal reflexes. There should be a wiggle. Now, if you use your pinwheel, it works probably even better. Okay? So you're looking at some thoracic roots with that. Alright? So sit down. Take your shoes off, please.
Oh boy.
And socks. Yeah, those are fancy socks right there.
Thanks, guys.
Yeah, really nice. Okay, so now we can check some reflexes down here. And of course we're in the lower extremities. Okay, so we've got a patellar, we've got an Achilles, there's a hamstring response. Yeah, and if anybody wants to kind of gather around up here, that's cool. There's a hamstring response, and then I'll show you some in the feet as well. Okay? Now, one of the things I like to do is I like the foot not to be on the ground because I want to see if there's any pendulousness of the reflex. And really, a pendulous response is not uncommon, and it doesn't necessarily mean you have a cerebellar lesion, but it can lead to that. So we can come down here, relax, and so here we are in this position. Now, what do you notice about that leg swing? It's about the same amount of swing as we saw in the upper extremities. So a lot of people will miss and hit the top of the knee. If you hear a hollow sound, like a donk, donk, you're over the kneecap. If it's more dull, you're down over the actual tendon. Now you can go to the top and get the same thing, but you're going to see the muscle contract up here. Right there, you see a contraction. Okay? Now, you want to make sure that that doesn't cause the whole leg to move or to jump or anything like that. Now, people who have really bad damage, where they may have like quadriparetic, you need to be careful with reflexes because you may hit that and they get spastic and it goes all the way up to their bladder, and now they have problems with, they may start to use the bathroom and they go into bladder spasms and then you can't stop it. So don't say, oh cool, look, it's hyper-reflexive, and keep doing it over and over, and everybody in the room's like, please don't do that. That's, the nurse said that doesn't work if they're like in the hospital or something, okay? So, turn sideways a little bit. Towards me, please. Okay, so pull your pant leg up. So now, some of you can't see this, so if you want to get into a position where you can see it, that's cool, stand up. You guys can come and gather around a little bit up front if you want. For an Achilles response, don't let the foot be in plantar flexion. It's not going to work. Does everybody understand? It's not going to work. So if you take the foot and just lift it a little bit, and then tap, see it move? This is the one where they're like, hey, let's just leave it like that. And then they're like, oh, there's no reflex there. Well, of course there's no reflex there, because the muscle's already in part contracted, or in a position where biomechanically you won't see it. So just take it up a little bit. Now, what do you notice about that movement? It's the same as here, it's the same as here, here, and here. So far, what we need to measure is the person to themselves. Is everything the same left to right? Are flexors the same as extensors? Because if somebody has hemisphericity or a little bit of change in one half of the brain versus the other, you may see extensors get weaker than flexors, or maybe flexors become dominant over extensors. So it's just a real simple, like that. Now, watch the toe. There's a little muscle out here called the extensor digitorum brevis. If you have entrapment up here in the top of the foot, like you're one of those females that wears like these giant heels every day, and so you have a lot of pressure here on the anterior part of your foot, and you're getting some numbness here. See the feet? Do you see the toe move? Watch again. Beautiful reflex. Now, with L5 or S1 lesions, the muscles that go away first are the smallest ones. So you may see a big divot here where there's no muscle, and now this guy starts to disappear. Beautiful. Now we can go on the inside of the foot to the abductor hallucis. More difficult, but you can come in here and tap and watch the big toe move outward. So watch. You see that move out? Turn towards the camera some. And you can see it moving really well right there.
What muscle is that again?
Abductor hallucis. This is the extensor digitorum brevis. It's a longus if it's up here. It's a brevis if it's in the foot. Okay, so we got that. We've got that. And now we can come down here and we can say, okay, what's your capillary refill look like? What do your toenails look like? Do you have a fungus? Now remember, if they have a fungus and you're sitting there playing with their foot and then you start touching your tongue and your mouth and everything, I'm not so sure that's the best idea. Okay? Now let's just go and talk about a plantar response. Call it a Babinski if it's positive. Don't say Babinski was negative. That's kind of the name of the test when it's positive. So say plantar responses were negative, or say Babinski was present. Start back here at the heel and then scrape. Now it's already negative. Did you see what happened? So watch real close. You want to look at the initial movement. So if the toe ends up being up, but the initial movement was down then up, it's still negative. So right here, it's done. You already know it's negative. Now if you do this and it doesn't have a downward movement, and his reflex afferent is exaggerated, and his toe comes whipping up, just come over here and start tapping around and doing some other things, and you'll start to see the toe it'll jump up a little bit. It'll kind of be antsy. Alright? Those are your upper motor findings. Now there's an abductor digiti quinati, or minimi. Down here, where you can take the broad end. For me, I do most of my reflexes with the pointy end, but you can use the broad end and tap and watch the little toe move. And it moves really well here. Alright, you see it? Now here's the reason why I'm telling you that. So we have 1, 2, 3, 4 down to the floor, 5 down to the side, S1 down here, S2 down this way. But the further down we get on the foot, the closer we get to the lower sacral nerve roots. So there's an important question as to, when do I talk about rectal tone and when do I not? Well, you should probably always ask, do you have any bowel or bladder loss? But if they've got good strength up here, pretty good strength here, they're starting to get weakness in the foot and weakness in the gastroc. The gastroc is S1, S2. This stuff up here, like the anterior tibialis, is 4 and 5. Out here is 5, S1. So if you're getting hit in S2, S3, as you come down towards the foot, there may be some S2 innervation, mostly S1. But if you're starting to get a lot of weakness in the foot, and people are having that saddle anesthesia, you need to then say, okay, what is your rectal tone like? So you may check rectal tone. Now, the question is, well, how do you do that? Well, yeah, you stick your finger in there, wear a glove, preferably, okay? Tell them you're going to do it. My microphone cable fell off.
I got gloves
You got some gloves? You know, the person that volunteers gets a free seminar, maybe. Let's don't, yeah. No, but really, if you're going to do that, and that's something that you want to find out, you'll just initially stick your finger there and have them contract around it and make sure there's tone. And then when they're contracting, pull into each quadrant, because it can denervate in one of 4 quadrants. So pull down, like, here's 9 o'clock, here's 3 o'clock, 6 o'clock, 12 o'clock. Just pull in between those. So it's in, pull down a little bit, and see if any of them just give. All right? And if that's the case, then there may be some... And here's the reason why it's important to know. If you denervate pudendally or through lower sacral roots, if you denervate that area, smaller muscles go fast. So if you denervate that area and you've denervated it to the point to where you can't re-innervate it, then there's going to be problems in the future. It's not like a quadricep where if you lose a little, nobody will probably know. Everybody's going to know if you lose a little bit of that. So don't be the guy that misses it. Just simply ask questions, and if you need to check it, check it. If you don't feel comfortable checking it, send it to somebody. Send them, don't just send it, send the whole person with it. Send that person to an individual that's pretty good at testing that stuff. Okay, so reflex hammer, start top all the way down. Now notice there's one thing that's very interesting about this hammer. Is that cold or warm? It's cold, typically. Okay, so remember when I was talking to you about, can you pull your pant leg up? When we were talking earlier about polyneuropathies. Okay, so cold. Okay, cold. Cold.
Yep.
Yeah. Okay. It will be a little bit less distally because his foot's cold. Do you understand that? So now go to the top. That's cold. Okay. So if their foot is cold, this is not a good test because as you stick this on there, the difference between the temperature of this and their foot is not that great, so they don't perceive it that well. But if their temperature of their foot tends to be the same as it is up here, then you can start right here and just say, tell me when this starts to get cold. And they're like, right there. You can mark that. And then what you'll do is, for each fiber type, you mark where the stalking begins and ends. And you can see the hair on his legs is pretty evenly distributed, so it's not that bad. But when you have small fiber damage and the autonomic nervous system gets damaged, then the actual hair follicle itself gets damaged and falls out. And now right where the stalking is, typically there's no hair in that area. And a lot of people will be like, nah, man, I got work boots. I wear work boots every day. I'm like, well, how tight are your work boots? I mean, it doesn't usually cause hair loss. All right? So this is a reflex hammer and how you can play with this thing. The things you want to make sure of is, do you have any upper motor findings or lower motor findings? What do the extensors look like compared to the flexors? What does the left look like compared to the right? And what does the upper look like compared to the lower? Learn how to use the same amount of force at each level, and then learn how to get the limb in the position mechanically to where you're going to get the best response. And then compare, I showed you how all of these reflexes moved about the same. And then always make sure, is there any clonus with it? So you can come down here finally to the foot, and you can rapidly dorsiflex it, and then feel if there's any beats. Now I can tell you on a lot of patients you'll feel maybe 1 or 2 beats. It's not sustained. And it's not necessarily the most unusual finding in the world. If you have that with no other upper motor findings, it's probably not something to stress out about. But if you've got hyperreflexia, that toe going up or down is kind of questionable, you know, and then you have clonus and there's like 5 or 6 beats, you probably have upper motor findings. Okay? Compare this with the other observations that we did in the last practical. Sound good? Okay, that's reflexes.